Professor Parulekar from Canada. Welcome to eCancer TV, and thank you very much for taking a break from this busy ASCO. Now, we interviewed Malcolm Mason from the UK about the big prostate trial which has been presented here all over the newspapers. It's a global study, or a North American European study, and you represent the NCIC, National Cancer Institute Canada, bit of that. Tell us a bit about yourself and NCIC and Kingston.
Pleasure. Thank you for giving me this opportunity. I work for the NCIC Clinical Trials Group. We're a non-profit, non-governmental organization. We conduct clinical trials in cancer, both hematologic and solid tumor malignancies. We're located in Kingston, Ontario, Canada, between Toronto and Montreal.
Which is a nice place.
Absolutely.
Okay, and so you're a breast cancer practitioner, but you're also a medical oncologist, and you're also in charge of a lot of the supervision, a lot of the trial, the data collection, analysis, and so on. Is that about right?
That's a nice summary, yes. I am the project lead on a number of national and international studies. My portfolio includes genital urinary malignancies, breast cancer, as well as head and neck cancer.
Good. So tell us about the prostate study.
Well, briefly, this is a study that we started in collaboration with other groups, such as the Medical Research Council and Southwest Oncology Group in 1995. We accrued 1,205 patients from 1995 to 2005, and the results that are being presented at ASCO here represent an interim analysis on overall survival.
So it's interim analysis. We haven't even reached the end of it yet. You've been going for 15 years. No?
Essentially, the Data Safety Monitoring Committee, which oversees this study, thought the results were important enough to disclose to the medical community and patients as well.
Why?
Well, this study asks a fundamental question. What is the impact of radiotherapy in patients with high-risk prostate cancer? We randomize patients to either hormone therapy, lifelong, or hormone therapy with radiotherapy. And to tell you the truth, until recently, that question has never really been answered, although radiotherapy may have been used with different frequencies and different practices up until now.
And what happened?
Well, radiotherapy improves outcome. So we found an improvement in overall survival, that there was a 23% decrease, really, in the risk of dying, and also a 43% decrease in the risk of dying from prostate cancer.
That's a big difference.
Absolutely.
I mean, I could see why your data monitoring committee got excited about that. And why do you think? Why is the radiotherapy working?
Well, radiotherapy is
local control matters.
Yes, local control does appear to matter.
We medical oncologists don't always rate local control maybe as highly as we should, but here is a fabulous advertisement for local control. So this wonderful, simple, urology-driven hormone treatment has got to go out the window. You think this is now standard medicine? Well,
it's certainly one of the treatment options. This is the largest study in this group of patients that shows that there's a difference. And really, in practices where radiotherapy is already being given, this allows the practitioner as well as the patient to really understand what the options and the outcomes are. For those practices that use really just hormone therapy, now is the time to start discussing radiotherapy as an option.
So even giving radiotherapy later on to a patient who's had hormone therapy, let's say for a year, 2 years, you would still advocate that?
We don't know that.
You don't know that yet. Okay, that was a careful response. Very good. So just say one more time. The standard, gold standard care for men with localized prostate cancer but high risk is, according to your study,
to consider radiotherapy in combination with hormone therapy.
Well, that's terribly important, and I hope that people watching this all over the world will change their practice if they're not already doing this. So tell me about the other interests you have and the other things that you're interested in here at ASCO.
There are a lot of important results that are being treated. My primary focus at this point really was the genital urinary symposium. So in addition to the PR3 results, we heard about the French results with a similar patient population looking at a biochemical endpoint. We're also able to look at antibody therapy for patients with advanced or castration-resistant prostate cancer with skeletal-related events already being treated with zoledronic acid. I think those are important results and are really advancing the field of treatment for prostate cancer.
So that's another shift of care, do you think? Addition of zoledronic acid? You think that data is as chunky and as big as your data on the on the radiotherapy hormone trial?
I like to focus on the trial that we did. I think that our trial has a global impact,
Sure.
which is what makes it so important. That this group of patients really still exists. It might be about 15 to 25% of patients that are currently diagnosed with prostate cancer. In addition to that, in many countries, radiotherapy is an accepted modality or available modality. And so this has the real opportunity to save many, many lives.
And probably many more lives than many of the sexy targeted treatments that are being bandied around with 2 months improvement in progression-free survival, which is negligible if you as a patient is getting that 2 months. Very important result, and I'm very, very pleased that you took some time to tell us about it.
Pleasure. Thank you
Thank you very much.